Well, good afternoon, everyone. My name is Bernie Rossoff, and I'd like to welcome all to the second day of the public meeting for the Committee for the Assessment of NIH Research on Autoimmune Diseases. This is a congressionally mandated study that is sponsored by the National Institutes of Health. I'm joined by the committee members who are all participating virtually. And for those new to this meeting and not in attendance yesterday, I will ask them to introduce themselves shortly. But before we proceed, I want to note that this is an open, on-the-record session. This is an information gathering session, which means that the committee is in the process of assembling materials that it will examine and discuss in the course of making its findings, making its conclusions and recommendations. Therefore, I want to mention once again that the committee has made no conclusions and is still gathering information for its report. Comments made by individuals, including the invited speakers and members of the committee, should not be interpreted as positions of the committee or necessarily of the academies. In addition, committee members typically ask some rather probing questions during the question information gathering sessions that may not be necessarily indicative of their personal views. The committee will deliberate thoroughly before writing its final draft report. Moreover, once the draft report is written, it must go through a rather rigorous review, as many around the room know, by experts who are anonymous to the committee. And the committee must then respond to this review with appropriate revisions that adequately satisfy the Academy's Report Review Committee and the NAS president before it is considered an official Academy's report. Yesterday, in a rather interesting session, we heard from speakers representing a subset of the institutes and centers that fund autoimmune research at the NIH and program offices, who provided us with insights into the funding priorities and the strategic process for their various institutes. Today, we'll hear from experts speaking about scientific advances for 4 autoimmune diseases: multiple sclerosis, autoimmune arthritis, type 1 diabetes, and inflammatory bowel disease. First, we have Dr. Nicholas Laraca speaking about multiple sclerosis, followed by Dr. Emily Van Cheven and Dr. Mary Crow speaking about autoimmune arthritis in the pediatric and adult populations. And then Dr. Sanjoy Dutta will speak about type 1 diabetes. And finally, Dr. Karen Heller speaking about inflammatory bowel disease. Please note, as I stated yesterday, that this public session and invited speakers represent the start of our dialogue with experts from NIH and from relevant disease groups. The committee will continue to invite other speakers as needed for upcoming meetings. Regarding the format for today's discussion, after each speaker's remarks, the committee will be able to ask very brief, clarifying questions. All attendees can indicate their questions or comments at any time during the meeting, during the event, by typing them into the Q&A box at the bottom of your screen. The Academy study team will be tracking comments for speakers and the committee and our committee. Those who would like to speak with members of the committee are kindly asked, specifically if they want to speak later after this meeting, are kindly asked to touch base with the staff officer, Henrietta Awo Osayantu, by emailing autoimmunestudy@nas.edu. That's autoimmunestudy@nas.edu. Once again, this meeting is being recorded. Now, I'd like to ask the committee members to briefly introduce themselves, giving their names and current affiliations. By the way, brief bios of everybody is available online. My name is Bernie Rossoff. I'm a gastroenterologist. I'm professor of medicine at the Zicker School of Medicine at Hofstra University in Northwell. I'm on the board of directors of Huntington Hospital, Northwell Health, and the board of advisors for the Northwell Health System. Glinda?
Hi, I'm Glinda Cooper. I'm an epidemiologist, and my work in autoimmune diseases was at the NIEHS and at EPA, and I'm now the Director of Science and Research at the Innocence Project.
Deirdre?
Hi, I'm Deidre Cruz. I'm a nephrologist and professor of medicine at Johns Hopkins, where I'm also Associate Director for Research Development at our Center for Health Equity.
Bill?
I'm an immunologist and vice provost for research at East Tennessee State University and spent quite a few years at NIH managing and directing clinical trials programs in infectious disease, autoimmunity, and transplantation.
Sonia?
I'm an associate professor of medicine at Harvard Medical School and Brigham and Women's Hospital in Boston, and I'm director of women's health at the Center of Crohn's and Colitis, and I'm a clinical gastroenterologist.
Lisa?
I'm Lisa Iasone. I'm professor of medicine at Harvard Medical School, based at the Mongan Institute for Health Policy at the Massachusetts General Hospital. And my focus is on healthcare disparities for people with disability.
Andrea?
I'm a pediatric rheumatologist at the Hospital for Sick Children and assistant professor of pediatrics at the University of Toronto. And I have a research interest in lupus and mental health for children with rheumatologic disease.
Michael?
I'm Michael Auction. I'm professor of medicine and obstetrics gynecology at Weill Cornell and the Hospital for Special Surgery. I've spent my career dealing with autoimmune diseases, particularly those affecting women, and I have a distant history of being extramural director, then acting director of NIAMS.
Jill?
Hi, I'm Jill Norris. I'm professor and chair of epidemiology at the Colorado School of Public Health. My research involves the nutrition epidemiology of type 1 diabetes, celiac disease, RA, as well as lupus.
Emily?
Good afternoon. I'm Emily Summers. I'm an associate professor in the Division of Rheumatology at the University of Michigan. I'm trained as an epidemiologist and I specialize in lupus and autoimmune diseases with also a focus in environmental health sciences and women's health.
I must say, as chair of this committee, it's been a pleasure to have this body of experts around the table really to inform the nature of our study. So it's been my pleasure. I'd like Henrietta Awo to just introduce the team that's been instrumental in creating this meeting and all our work.
Yes, good afternoon to all. I am the study director for this meeting from the NASM end, and I work with a team of staff to support the committee's work. So I have Kristen White, who's an associate program officer, Dara Rosenberg, Layla Maymand, who all support the work that we do.
And Rose, are you here?
I am. Good afternoon. I'm Rose Martinez. I direct the Board on Population Health and Public Health Practice that this study sits under. Thank you.
And thank you for being with us, Rose. Thanks very much. So let me introduce the first speaker, who will be Dr. Nicholas LaRocca. Dr. LaRocca is a clinical psychologist who has worked in the field of multiple sclerosis for over 30 years. He is currently a consultant with the National Multiple Sclerosis Society. He previously served as Vice President of Healthcare Delivery and Policy Research in the Advocacy Services and Research Department of the Society. In this role, he has responsibility for society funding of research to address the symptoms of multiple sclerosis, rehabilitation, epidemiology, psychosocial aspects of multiple sclerosis, as well as health policy studies. Dr. LaRocca.
Thank you. Okay, I want to thank you for the invitation to participate in this very important meeting. And it's a sort of deja vu for me. 20 years ago, the National MS Society financed a study of multiple sclerosis which was conducted by the Institute of Medicine, which is the precursor to this academy. And I believe that we pretty much followed the recommendations that came out of that report. So in a sense, today we're sort of turning in our homework in a sense. The National MS Society was founded in 1946. It was founded by Sylvia Lowry, whose brother Bernard had fairly severe multiple sclerosis. And they were unable to really find any resources. And so Sylvia decided, well, if there were no resources, that she would have to start an organization and build from there. That brings us. Sorry about that. Okay, we can go to the next slide. So today I want to talk about a recent update of the prevalence of multiple sclerosis in the United States, which was conducted by a group put together by the National MS Society. I'm also going to talk about recent research advances in MS and talk about the existing scientific and research gaps in multiple sclerosis, which we'll refer to as pathways to cures for MS. And next slide. And the next slide. So the beginning of this project dates back to 2006 when the CDC and ATSGR brought together representatives from the ALS, Parkinson's, and MS communities to discuss the feasibility of doing prevalence studies of neurological disorders, basically in order to facilitate the identification of environmental risk factors. An outgrowth of these early meetings was the funding and the establishment of the ALS registry, which continues today. Also in 2008, the MS and the Parkinson's communities drafted similar legislation to establish a neurological condition surveillance system that went through a number of different versions. It was introduced in Congress, more than one. And Congress, over several years, failed to pass the legislation. In 2014, the National MS Society, being frustrated by the inaction of Congress, decided to fund a national prevalence study of multiple sclerosis using our own funds. In 2016, Congress finally did pass, and President Obama signed legislation establishing the NNCSS. And in 2019, our prevalence work group published what was the first comprehensive prevalence study of MS since 1976. So I'm going to talk about that now. And the National Neurological Condition Surveillance System it continues to be funded. Hopefully it will be funded on a continuing basis. And the Parkinson's community and the MS community have continued to work closely with them as they develop the surveillance system. Next slide. So there have been a number of studies of the prevalence of multiple sclerosis over the years. The trend has been for the prevalence rate to increase over that time, with just one or two exceptions. You can go to the next slide. When we set out to do a national study of prevalence, we realized that there were going to be a number of challenges. The previous estimate of 400,000, which was pretty much the largest to date, had been based on the data that had been collected in 1976. There was currently no surveillance system to track neurological conditions in the US. And because of the lack of a unified healthcare system in the United States, it's really very, very challenging to try to identify and track patients. Next slide. And part of the challenge is that in order to identify patients, it's necessary to really deal with a number of different institutions and a number of different ways in which healthcare is delivered and financed. And so it was necessary for us to focus on those segments of the population which were accessible. Next slide. So we looked at a number of different options. In 1976, sort of traditional epidemiology was utilized, in which there was chart reviews in doctors' offices and health facilities. The ATSDR and the CDC had really concluded that trying to do this on a national basis, probably not feasible for a number of reasons. We also thought about adding some questions to an existing survey, but experience had suggested that this was not necessarily a very reliable way to do epidemiology. We could have used an existing registry or built a new registry with mandated reporting, but this was impractical and probably not at all feasible because of the way in which disease registries are set up. We considered using electronic medical records, but when we started in 2014, although electronic medical records had made a good deal of penetration in the healthcare field, we really didn't think that use of electronic medical records as our sole approach was really ready for prime time at that point. Mining administrative data was the approach that seemed to be the most promising, and it was the approach that was supported by ATSDR. And ATSDR had funded some pilot studies to look at the feasibility of doing this. We also considered, well, could we maybe combine two or more of the above? But we decided that trying to do that would probably be unaffordable. Next slide. So the approach that we finally took was to develop several candidate algorithms that we could use to search existing claims data sets and identify individuals with MS. In the adult population, we decided not to try and assess the pediatric population for a number of reasons, including the fact that we did know that that population was relatively small to begin with. So we tested several algorithms, selected the one that proved to be most accurate in the testing, and then applied those algorithms to three types of administrative data sets: private insurance, Medicare, Medicaid, and Veterans Administration. Next slide. So those are the different algorithms that we tested. I'm not going to go through all of those. We can go on to the next slide. Okay. And the algorithm that was finally judged most accurate based on the testing was to identify a case of multiple sclerosis. Anyone who had a combination of any three of the following: an inpatient encounter, an outpatient encounter, and a prescription for one of the MS disease-modifying drugs. And the use of a prescription for an MS disease-modifying drug was supported by the fact that, that those drugs essentially have no use other than for the treatment of MS. Next slide. And there was a number of testing using traditional methods to evaluate the candidate algorithms. Next slide. Okay. We put that algorithm to work. We assessed period prevalence for three years. We then assessed cumulative prevalence by combining the information from those 3 years. We merged those data, adjusted the estimates, and then extrapolated the results to a 10-year cumulative prevalence, which was then adjusted for population growth up to 2017. And let me just say a few words about the use of a 10-year cumulative prevalence. Next slide. We looked at 3 data sets in which we had very good clinical diagnostic data. And we found that if we did a cumulative prevalence for a 3-year period, it really seriously underestimated the prevalence of multiple sclerosis. So we looked at this in the VA data set. Next slide. In a data set from Manitoba in Canada. Next slide. And also a data set for private claims, private healthcare claims. Next slide. So when all was said and done, we estimated that the national prevalence of multiple sclerosis was very close to 1 million, which represented quite a significant increase from the previous estimates. Next slide. And the reasons why this estimate was higher, other than because of the methodology which we utilized, there was population growth, obviously. The aging of the US population meant that there were more people in the age groups that have a higher prevalence of MS. The life expectancy of people with MS had been increasing. Improved diagnostic criteria meant that cases of MS were being identified earlier and more quickly. And also the availability of effective MS therapies meant that people diagnosed with MS had a much more compelling reason to see their physician, see their neurologist, and to have contact with the healthcare system. Next slide. Okay. And these were the members of our working group. Mitch Wallin is an MS neurologist at the VA in Washington, D.C., and also works very closely with the National MS Society. Next slide. So the next thing I'd like to talk about are recent advances in multiple sclerosis. Next slide. And we decided to organize this along the lines of what we refer to as the pathways to cures for MS. And so it refers to 3 approaches: stopping multiple sclerosis in people who were already diagnosed, restoring function for those people, and then ending MS forever so that hopefully no one will ever develop MS at some point in the future. Some of the important developments that have occurred recently, and probably the one that is the most prominent, is the fact that there are a large number of immunomodulating treatments for multiple sclerosis, whereas when I started in the field, there really was no effective treatment for MS. And this development has continued to the present day. In fact, yesterday we just heard about one new development in which the way in which an existing treatment is being administered was expanded. Another important development has been the advance and refinement of neuroimaging and early work looking at biomarkers that could track progression and also track response to treatment. There have been very significant developments in terms of diagnostic methods for multiple sclerosis. We have learned a tremendous amount about the role that comorbidities and aging have in terms of the impact of MS on individuals. And most recently, interest in understanding the potential role of diet and the impact on the microbiome have also occurred. Next slide. When I first started in multiple sclerosis, there was very little thought or effort paid toward trying to restore function. So there have been tremendous advances in terms of the impact of rehabilitation and wellness interventions in multiple sclerosis. There has been a real explosion of research looking at the repair mechanisms and the barriers to repair mechanisms, including the effects of aging on tissue repair in the central nervous system. And also there's been advances in terms of understanding the heterogeneity of MS. Next slide. And ending MS forever. There's been significant work looking at the genetic, epigenetic, and environmental and lifestyle risk factors for multiple sclerosis. There's been a lot of work very recently looking at the prodromal phases of MS, and there is evidence that there are prodromal signs in individuals who eventually develop MS, which may inform us in the future about some of the risk factors. Pediatric MS is now subject to very intensive research, and we've learned a tremendous amount about the impact of MS in the pediatric population. And of course, epidemiology of MS. I only spoke about the prevalence of multiple sclerosis, but there's been quite a bit of work looking at other facets of epidemiology of MS. And next slide. Okay, so what are we missing? What do we need to do to really address those three goals that we have: stop, restore, and end? So let's take a look at the next slide. We need to get a better develop a better understanding of the heterogeneity of MS pathology. We need to identify and begin to utilize biomarkers for therapy response. We need to get a better sense of the way in which inflammation is driving neurodegeneration. And also, we need to get a better understanding of why MS progresses from a relapsing form to a progressive form. Next slide. Biomarkers are also going to be, hopefully, in the future, predictors of MS. We need to have better understanding of the earliest pathological events in multiple sclerosis. And we also need to have a better understanding of the effectiveness of early treatment and how they can impact on progression. Next slide. It's very important that we develop ways to understand and to intervene in repair failure. We know the central nervous system has natural repair mechanisms which simply don't seem to go far enough to really make a difference. We need to do better understanding of the impact of oligodendroglia on central nervous system repair. We need to find ways to limit the damage that's done by multiple sclerosis in the CNS. And we need to understand what are the possible effects of age, sex, and genetics on central nervous system repair. Next slide. We need to have a better understanding of the ways in which rehabilitation, exercise, and the dosing of those interventions can have on CNS repair. We need to identify what are the best outcome measures for evaluating the impact of those interventions. And we need to understand what are the mechanisms that might underlie the improvement of symptoms in MS. And next slide. Okay. So we need to have a full understanding of all the risk factors which contribute to the development of MS and what their time frame is. We need to add to what we already know about the genetic and epigenetic factors in the etiology of MS in particular. And we need to identify potential public health interventions that may reduce the development of multiple sclerosis by addressing those risk factors. And the next slide. Okay. And once again, biomarkers are going to be important in the future, particularly if we can identify biomarkers that predict the development of MS, and also biomarkers that might identify what are the most effective early interventions. We really need to identify those that are at higher risk for multiple sclerosis. We need to identify, again, early pathological events and ways to intervene in them. And we need to develop effective early interventions so that multiple sclerosis does not become a lifetime of progression. And the next slide. Okay. So I hope that I have addressed the charge from the committee. If you are interested in additional information about multiple sclerosis, our website has a tremendous amount of information about multiple sclerosis, and also anyone who is diagnosed with MS or has a family member or friend who's diagnosed with MS. We have an MS Navigator program at the end of an 800 number. And navigators can provide a tremendous amount of information about resources, referrals, et cetera. And the last slide. These are two citations to the epidemiologic study of prevalence that I reported on. And lastly, the citation to the Institute of Medicine report, which I mentioned at the beginning. That report was funded by the National MS Society, carried out by the Institute of Medicine, along with the contractor. Dr. Lisa Iazzoni was a participant in that effort as well. So that's the end of my presentation, and I want to thank you for the opportunity to take this very quick tour of multiple sclerosis. Thank you.
So thank you so much, Dr. LaRocca. If committee members have questions, please use, as we did yesterday, the raise hands feature in the participants tab at the bottom of the screen. I'll call on you to speak before you ask your question. Please identify yourself, helpful to the recordings. Michael, I think you had a couple of questions on the chat.
I did, and one is, and I think you've already probably answered that. When you speak of MS, you are talking about all the prodromal phases and everything else, and not just when you do epidemiologic studies, you end up with ICD codes, but I gather your interests are going to be in the whole spectrum of the disease, not just that which meets diagnostic criteria. That's the first question. The second one is rather more simple. This is an NIH advisory committee. So what would you think NIH should do differently or better or worse with regard to MS?
A couple of thoughts. I think that what seemed to me to be an underlying theme of this meeting was whether the way the NIH has organized the support for autoimmune diseases, if this is the best way to do it, or is there a better way to approach this? And so, for example, multiple sclerosis is in the Neurological Institute. Is that necessarily the best place for it, or would there be a better way to organize the support of research for these types of disorders? I think that's an important question. It's certainly something that we've talked about over the years. NINDS is the main federal supporter of multiple sclerosis research, but there's multiple sclerosis research, sort of scattered in a few other places. And when I was on an NIH committee on rehabilitation, we talked a lot about the fact that rehabilitation is sort of spread all over in a number of different institutes. And so there's always that question of, is it better to centralize certain things, or is it better to break them up into some sort of logical pattern? So I think that's an important issue to think about, and maybe after considering that, the conclusion would be, well, the way things are organized now is probably the best, or maybe there could be some changes. So sorry for the long-winded response, but those are my thoughts.
Lisa?
Thank you, Nicholas, for a very organized and informative talk. And I wanted to just build on Michael's question. And that is that you did lay out a very kind of organized set of items that you think really should be addressed in MS research to move forward towards your ultimate goals. And I wonder the extent to which NIH you envision NIH being involved in different aspects of that versus some other federal agencies, private philanthropies, what you think the specific role of NIH is compared to other organizations that might fund you. And then after you answer that question, I'd love to hear what your use of the word cure actually means.
Okay. Well, I think that I'll answer the last question first. I think that we have struggled with the word cure. It's a word that sort of dates back to the Dark Ages. And I think for a while we were very hesitant to use that term, partly because many people felt, well, you're sort of bamboozling people, that you're sort of fooling people into thinking there's going to be a cure. And so you saw today, and I know you're familiar with it, this whole concept of pathways to cures. And it draws on a way of thinking that the society developed where we looked at cures in a very broad way. So it's stop, restore, and end. And what that means is that there are different ways to conceptualize what a cure is. And different people have different ideas about what a cure means. And that list that I showed you, which looks very neat and orderly, was actually the result, as you might imagine, of many, many meetings and arguments and really trying to figure out what do we really need to do and what our goals should be. And so I think we're at the point now where we're comfortable referring to pathways to cures, with cures being a multifaceted concept. Getting back to the NIH, I think that in certain institutes of the NIH, the concept is that we should be funding basic research. And of course, during my tenure in the field of multiple sclerosis, I was one of the people who fought for rehabilitation and for clinical research. So obviously, I think you need both. And I think you also need to support research in different ways. You need to support the education of researchers. You need to support basic research. You need to support the intervention in disorders. And so I think you have to do all of those. And I think that the NIH has to define for itself where it stands in that spectrum of approaches, and where will each of those types of research live. Because if we just focus on one of those things, if we just focus on rehabilitation and we don't do basic research, that's not a good idea, and vice versa. And so I think the trick is to figure out what's the balance, what should be the role of the NIH, who outside the NIH should be supporting some of the other goals. And I imagine that's part of why this meeting is being held.
Thank you very much. They're very informative comments, and thank you for the question in addition, Lisa. Let's move on to the next. Any questions that we have for Dr. LaRocca, we can bring back towards the end of the meeting when we have time allotted for further questions. The next speakers are Dr. Emily Van Scheven and Dr. Mary Crow. Emily is a pediatric rheumatologist with a special interest in the long-term health of children with chronic illness. She cares for children with all rheumatic conditions, including lupus. At UCSF, She serves as Division Chief for Pediatric Rheumatology and is founder and director of the Child and Adolescent Chronic Illness Center. Dr. Crow has held a number of leadership roles at HSS, Hospital for Special Surgery, and at the Weill Cornell New York Presby. And she has served as president of the American College of Rheumatology, president of the Henry Kunkel Society, and chair of the Scientific Advisory Board of the Alliance for Lupus Research and the Lupus Research Alliance from 2008 to 2019. The topic will be advances and opportunities in autoimmune arthritis. Emily, I think you're going first.
Sure, let me just share my slides. Does that look right? So thank you so much for inviting me to speak today and to share this time with Dr. Crow. It's really great that we're including pediatric rheumatology in this meeting. As mentioned, I'm a pediatric rheumatologist at UCSF, where I serve as division chief, and I take care of patients in the clinics here and conduct clinical research. And I'm also president of the Childhood Arthritis and Rheumatology Research Alliance, CARRA, and we'll be telling you a little bit more about that organization later. So here are my disclosures. So the childhood rheumatic diseases are varied. There are many. I can't talk about each one separately. Some of them are unique to children. Some of them are similar to what is seen in adults, and they are really all syndromes defined by a constellation of symptoms. I include COVID-associated multisystem inflammatory syndrome of childhood, sort of the new rheumatologic disease on the block. We typically don't think that there's an increasing incidence of childhood rheumatic diseases, but clearly we have a new disease here, which the rheumatologists are very involved in caring for. The most common is JIA, juvenile idiopathic arthritis, that used to be called JRA, juvenile rheumatoid arthritis, but really was renamed because of its distinctions from adult RA, which you'll hear a little bit more about next. But JIA is not one disease either, right? JIA is diagnosed with these clinical criteria, and there are actually many, many subtypes. And this is, I think, important because we use these clinical criteria to prognosticate, to tell patients and families what to expect in terms of outcomes. We use these criteria and classifications to direct our therapy, and we use them to define who goes into our clinical trials. And yet what we're learning is that those clinical criteria probably are not accurate. So as we've had an emergence of new laboratory methods like gene expression profiling and microarray, we've learned a lot more about the biology of these conditions, and we're learning that the biologic phenotyping doesn't always match the clinical classification schema that we use. We're finding that patients categorized as polyarticular JIA based on the number of joints they have, some of them actually look a lot like oligoarticular JIA. And we're finding that a lot of the patients that we call polyarticular JIA look a lot like adult rheumatoid arthritis, and maybe they should really just be considered a young age onset of adult RA. And there's a movement now of thinking that we really need to start to transition to more biologic-based classification criteria. So there's certainly a need to better understand the biologic basis of disease, but also then to use it in our classification schema to do a better job at deciding how to treat patients. In terms of epidemiology, we generally, as a group, say that these are conditions that are more common in females. In many diseases, they're more common in Caucasians, but not true across the board, and that there's about 300,000 children in North America with chronic arthritis. But if you look at the published prevalence rates, you'll find a lot of variability. So we need better epidemiologic data by disease, by geographic region, by race and ethnicity. We still have most patients coming to see a pediatric rheumatologist, but not all, and most coming to an academic center, but a lot of challenges around obtaining reliable epidemiologic data. So there's certainly still gaps there. As for all autoimmune diseases, there are gaps in understanding of the etiology of diseases, and we mostly consider these to be multifactorial conditions with genetic predisposition and probably some environmental triggers. Understanding these factors requires more work. I want to highlight the monogenic diseases, though, the conditions that are attributable to single gene mutations. There's been a growing number of conditions, mostly in the autoinflammatory syndrome group and in early onset lupus syndromes that have been identified. Every year we seem to be identifying more, and research in this area is really valuable, both to better understand the basic mechanisms of autoimmunity, but also to lead us to strategies of personalized medicine, and in some cases actually lead us to cure. Many of these kids are treatable with bone marrow transplantation. In terms of outcomes, we have come a long way. There have been tremendous advancements in treatment that have resulted in improvement in disability in terms of physical disability. We don't see kids like those shown on the far left anymore very often, and we don't see kids in wheelchairs very often. But what that means is that we have new questions to address. We need to start to think about prevention. We need to think about all of the comorbidities that emerge in these patients across a lifetime, because we are graduating to the adult rheumatologists, adults with chronic illness, with many years of accumulated exposure to disease and accumulated exposure to medication and secondary morbidities such as early onset cardiovascular disease and a host of emotional issues. So we need to start to focus on reducing morbidity and reducing it across a whole lifetime and taking a life course perspective. And of course, we need to think more and work more in terms of cure. Now, the advances have come mostly from this explosion in medications that have become available, similar to MS and IBD, and have really transformed the care that we can offer. Yet, despite all of these medications, many of which we've adopted from the adult space, we still have patients who don't respond to any of them. So we still need new medications, but we also need to better understand how to use the medicines that we do have. We need to better understand which medicine is going to work for which patient, which involves both really translational research. And then for those that do respond, we need to start to understand when we can stop medicines. And the families are telling us this loud and clear. If my child is in remission on meds after 1 year, after 2 years, can I stop them? Will it come back? And we need to start to think about research that helps us answer that question, as well as how to treat the patients that don't respond to what we have. We know that treatment's a really important predictor of outcome, but it's not the only. And there are clearly genetic factors and environmental factors and an array of social determinants of health and access to care phenomenon, all of which are still really poorly understood and areas of focus for future research. And we, as much as we attempt to really learn from what's happening in adult studies and adopt the learnings from adults to the care of children, there are times when we can't do that. There are some fundamental differences around pediatric rheumatic diseases that need to be considered in terms of the impact both of disease and drugs on growth and development, and also safety profiles being different in kids. There's certainly differences around clinical trial equipoise and how we design studies and think about the use of placebo and study designs that are important. So we need to study these diseases in kids, and that was really the impetus for the formation of CARRA, which is the Childhood Arthritis and Rheumatology Research Alliance, which was, we have a strong partnership with the Arthritis Foundation, and it's that support that's really allowed us to grow this research network in the way that we have. It's an investigator-led research network so that we can be motivated and prioritize the questions of researchers and patients and not just pharma. It has reach across all of North America and many sites where these patients are cared for, which allows us to get into the clinics for recruitment and clinical studies. And at its core has a strong registry, which is 21 CFR 11 compliant and allows for us to perform the post-marketing surveillance work for pharma, and now has over 10,000 patients enrolled. And our research portfolio crosses a whole array of really early translational studies to implementation studies, and we have biospecimens on a large number of patients that are all in the registry, so we have good clinical data on and phenotyping for those samples. In terms of priorities, I want to highlight that there's a really nice growing body of literature of published scientific research agendas that have come out of systematic prioritization exercises, many in collaboration with the patients and the families, that provide, I think, a really valuable roadmap for informing both researchers and initiatives and also funding agencies across the range of translational to clinical and clinical practice. So in terms of content areas that need to be addressed in future research, I think related to health and biology, there's a lot of information out there to say what the community feels is a priority. I also want to add that I think that we need to make a priority looking at innovation around our methods and around resource development. I think we need to push more into the area of implementation science, which is new to our field. I think we need to be thinking about innovative methods around trial design. I point you to this recent paper that came out of a collaborative activity and presentation at the FDA about innovative trial design for pediatric studies. With everything going remote, we need innovation around collecting data remotely and maybe collecting biomarkers remotely. I think we need to be focused more on prevention and looking at the role of environment and diet. In terms of building resources and collaboration, I think we could use more support in the area of optimizing team science approaches and partnerships that are really multi-stakeholder and interdisciplinary. And by that, I mean not just between different areas within health science, but even outside of the medical field into social science and other collaborations, and continue to build the workforce of researchers within our field because we are a small field. So I'm hopeful that, that the NIH will be interested in both advancements in terms of support in the area of some of the content and scientific areas I mentioned, but also thinking about how to drive innovation around methods and collaborative science. So I'll end there. I don't know if you want to ask me questions now or if
no, I think we'll wait for questions later, Emily,
okay.
in light of the time factor. But we'll have time later. Mary?
Okay, thank you so much. I'm going to stop sharing.
Yes, if you stop sharing, and I'll start sharing. Okay. Okay. So I am just ready to go here, and thanking you for inviting me to share some comments with you. I just want to emphasize that the Arthritis Foundation invited Emily and me to speak to you, but our comments are our own. And I'm particularly speaking to you from the point of view of an investigator, really driven for many, many years to understand these diseases with the goal of helping to achieve better outcomes for our patients. So autoimmune arthritis is not one disease, as I think has already become clear to you from Marie Mancini's talk yesterday and Emily's comments. We have a number of diseases that we study and treat that are characterized by arthritis, but they are much more than arthritis. Their prevalence is very, very different from disease to disease. Perhaps Sjogren's syndrome might be the most common. Arthritis Foundation estimates that there are about 4 million patients with Sjogren's syndrome in the US. Rheumatoid arthritis is quite a frequent disease, about 1.5 million people in the US. And then we include in this group of disorders others that are less common. Lupus, a recent study was just published in the last week or so, estimating a little more than 200,000 patients with lupus in the United States, and then other diseases such as systemic sclerosis or scleroderma and others. But what's
Sorry
very
to interrupt.
important, yes.
We are not seeing your slides.
Oh my goodness, okay.
If you want, I can share them for you.
Let me just try one more time. That's not good. Hold on. Are you seeing them now?
Yes, you just need to go
Okay,
into the
great.
presentation mode.
Okay, so I
You
am.
need to go into, there we go. Looks right.
Okay, great. Sorry about that. So yes, but in addition to all of these distinct diseases, we have to recognize that there are a number of patients who have what we might call overlap diseases, incomplete diseases, with features of several of these. And these diseases are going to be very, very important to characterize and understand at the biologic level. A very important point about these diseases is that they are not characterized just by arthritis, but they're systemic. And they have very, very significant organ system manifestations. For example, lupus and rheumatoid arthritis are characterized by premature atherosclerosis with significant increase in cardiovascular manifestations and contributions to death in those patients. A number of these diseases are characterized by lung disease, chronic nephritis. And what's very, very challenging, both clinically and in terms of research studies, is that the diseases are very heterogeneous from patient to patient. And as I said, there are patients who have manifestations that are features of one or the other or a number of these diseases. As has been mentioned yesterday, these diseases tend to be enriched in women. The Arthritis Foundation made this estimate that 1 in 12 women will develop an inflammatory autoimmune disease in their lifetime. Lupus and Sjogren's syndrome are most skewed, but rheumatoid arthritis and scleroderma are also significantly skewed toward women. Well, in reflecting what I wanted to tell you about, my own views about the value of research in these diseases, I wanted to highlight 2 discoveries that have just had tremendous impact on understanding and treatment of these systemic autoimmune diseases, and perhaps give us some guidance on the kind of research that can be fostered. So this discovery of the toll-like receptors, I think, changed everything for our understanding of this whole group of disorders. And from the mid-1990s, for the following couple of years, we understood what the ligands for these receptors were, and then went on to understand how we could connect the toll-like receptors and the innate immune response to understanding in a fairly specific way about how the immune system could be activated in diseases like lupus and rheumatoid arthritis and scleroderma. And it really did extend the understanding of what an autoimmune disease is, away from just thinking about the specificity of antibodies and T cells to understanding the important role of the innate immune response. Another very impactful approach to science is illustrated by this somewhat famous experiment from Brennan and Maney and Feldman, in which they studied human synovial tissue cells and showed that culture of those cells with anti-TNF and not with some other antibodies completely inhibited the pro-inflammatory function of those cells, obviously leading to many of the therapies that Emily cited anti-TNF therapies, as well as many, many others that have changed the course of disease. So the message here is that study of patient tissue, blood might be sufficient in some individuals, can be extremely informative, and that approach has been carried on, as has been mentioned in the Accelerating Medicines Partnership, which has been going on for several years now and has also made important contributions. Now, moving to some more recent observations that, in my own view, I think have been very informative and provide opportunities for being extended to make even more important observations. This is extending what Emily just pointed to, that I agree has been so informative and holds opportunities for even more very interesting observations relevant to a number of our immune-mediated diseases. So studies intramurally at NIH and by others through characterizing these monogenic disorders, not just at the clinical level, but at the biologic and biochemical level, immunologic level, have allowed us to define pathways such as the interferon pathway here, a more pro-inflammatory cytokine mechanism here, that then we can take to understanding the systemic diseases and define in individual patients or disorders how those different pathways are involved in mediating disease. The study of African Americans is really a burning need, and yet we have clues that there can be important progress in understanding those patients. This is one example that I'll point to, the discovery of the APOL1 gene, which has protective functions in Africa, but in African American patients can contribute in many disease settings to very severe renal disease. The study of this molecule is now being looked at the molecular level to understand how it's functioning. And a very recent study cited 14 times higher fatality rate in some lupus patients with the risk allele for this particular gene. So very important hints coming from study of these populations. Analysis of gene expression data is showing that African Americans who are healthy have very different skewing of their immune responses compared to European Americans. And this kind of data is very important in order to understand the mechanisms of disease in these patients. The checkpoint inhibitor therapy-induced inflammatory arthritis was mentioned yesterday, I think by Marie Mancini. And it's another area where we can cross disciplines and gain important insights into disease. A group that reported at our rheumatology meeting in the fall looked at the checkpoint inhibitor mediated arthritis, rheumatoid arthritis, and spondyloarthropathy related arthritis by single cell RNA sequencing, and to find a unique population of CD8 cells that is involved in this disease. So comparing and contrasting disease syndromes in this category, I think, is going to be very, very important and informative. The question of female skewing of autoimmune disease is really a burning issue that to some extent has not been studied in detail, because I think we've struggled to find the real important clues. But I think there's progress there, focusing on the X chromosome. Epidemiologic studies showed that X chromosome dosage may be a clue, and there has been a report of a particular gene encoded by the X chromosome that amplifies innate immune system signaling. So we're starting to get some ideas about how we can address that very important challenge of understanding female skewing in disease. The role of the environment has been of interest. There have been identification of factors such as smoking, recent data looking at the role of passive smoking in risk of rheumatoid arthritis. But I don't think we've yet understood the mechanism. What's the link between an external trigger and the biology of a disease that leads to pathogenesis? So many opportunities there. And then finally, I'm going to point to the value of studying infection-induced immune system activation. Emily noted the impact of COVID-related immune system activation, and now we're seeing autoimmunity, very, very similar to what we see in lupus in patients who had COVID. So extending research beyond the established models to look at, in an opportunistic way, how infection can trigger autoimmunity, I think can be very, very valuable. So I'll just sum up. We don't have to take the time to go through these points. I really made them, but so many opportunities, I think, we are seeing based on new observations. And I think the NIH can particularly perhaps play a role in encouraging collaborations across some of these groups, study of ethnic groups, African-American groups, particularly, I think is going to be very, very important. And crossing disciplines, both crossing diseases, crossing autoimmune diseases, and incorporating study of those patients who don't clearly fit into one of the categories, I think is going to be very, very important. And perhaps I should stop at this point. Thanks.
Well, thank you so much, both Emily and Mary. Very helpful to us in our thought process going forward, particularly in two diseases that we need to understand better. Again, I'm going to hold questions until the end, just to facilitate all the speakers. We are making notes both from the participant list and from the committee list for questions for later. So I'm going to move on to advances and opportunities in type 1 diabetes. Dr. Sanjoy Dutta is the Vice President of Research and Institutional Partnerships at the Juvenile Diabetes Research Foundation. And he oversees all of the research programs to treat type 1 diabetes and its complications, including the artificial pancreas, glucose control, beta cell replacement, and complication portfolios. Dr. Dutta.
Thank you very much to the panel and to my co-speakers for setting the stage up. And thanks for inviting type 1 diabetes as a topic. And I'll be representing JDRF. And I could almost see all the previous presentations and see it can be relevant for type 1 diabetes as well. But I've taken a little bit of a different approach, which I'll walk you through. So if I can have the next slide, please. A little bit of a background on JDRF for those unfamiliar with this not-for-profit organization. We're the largest charitable organization funding type 1 diabetes research and advocacy worldwide. We are actually in our 50th year now, as insulin is in its 100th year, the life-saving therapy and the only therapy right now for people with type 1 diabetes. We were actually founded by two mothers shown in the black and white picture there with the NIH director at the time. They're in the living room of one of the moms in Philadelphia because they both had, at the time, sons with type 1 diabetes and did not know where to go, what to do. And type 1 diabetes wasn't even categorized like that at that time. So it took a lot of family-driven grassroots advocacy to form and even today to lead the organization. And we pride ourselves in being very patient-centric in our approach here. Our vision, akin to some of my previous presenters, is a world without type 1 diabetes. Can we prevent it? Preventive therapies have always been more successful than curative ones. However, our mission is to find life-changing breakthroughs that can treat, prevent, and cure type 1 diabetes and its complications. So next slide, please. Another thing, and last slide about JDRF, is we also work the pipeline. We have in-house staff here in preclinical research and translational clinical research, regulatory policy, healthcare policy, as well as in more the outward-facing clinician education, patient education. And our only metric of success is people with diabetes doing better. And we work around the globe and across the pipeline here. So in a nutshell, I try to summarize what JDRF has been doing in about 50 years' time. And we work very closely with NIH and some of its divisions there. So next slide, please. So akin to the previous presenters, type 1 diabetes is also a growing disease. This slide is US-centric here. The numbers have been increasing, and right now it's estimated that 1.6 million Americans are living with type 1 diabetes that have been diagnosed with T1D here. And I might interchange between T1D and type 1 diabetes. However, the red boxes are the important figures here, is that there have been a 21% increase in less than a decade here, which surpasses all other rises in type 1 diabetes in the last 70, 80-year history. And it's estimated that 5 million people will have the disease by about the next 2 or 3 decades or so. If you go to the next slide here, this is, I had a hard time, next slide please. I had a hard time choosing which data graphic to show here. I picked one here which shows the increased incidence of type 1 diabetes and somewhat increasing prevalence as well around the globe. So what was believed to be a Caucasian primary or Caucasian only disease generating from the Caucasus Mountains here in the Scandinavian countries and then going into that population now has been seen to increase in all ethnic groups, and it can also be found in all age groups here. And I will get into a little more of what's on the left panel there about having a family history of type 1 diabetes does increase your risk 15-fold over general population. However, and very interestingly, 85 to 90% of the newly diagnosed cases do not have a known family member. So there's something that goes beyond the genetics, and there are environmental triggers of these, again, akin to some of my previous presenters there. And what are those, and what are those mechanisms is what we're exploring now. And also interestingly, and I know the chair introduced this as Juvenile Diabetes Research Foundation, which is what our name was up until 10, 12, 15 years ago, but research and findings have kind of forced us to change our name, and we kind of leave it at JDRF and not emphasize much on the juvenile aspect of it, because what we have learned now through epidemiological studies is that 50% of the newly diagnosed cases of type 1 diabetes happen in people over 18 years of age. So it is no longer a childhood only onset disease, although there is the severity of the disease seems to be higher if it's childhood onset as opposed to if it's adult onset. One more click, please. I just want to draw your attention to the 2 green circles there. And this is where the environmental aspects layers on top of or underneath, depending if you're a geneticist or not, on the highest incidences seen. Scandinavian countries were known for the last 30, 40, 50 years. But what we're also seeing in parts of the Middle East has some of the highest incidence, even higher than North America, which has a pretty high incidence. So there are some very interesting learnings coming out of these epidemiological studies that are lending clues towards what direction research should be going into, as well as interventional therapies be discovered for. Next slide, please. Thank you for doing my slides. A little bit on JDR research priorities. Since I only had 20 minutes, I had to select. So broadly speaking, we cover the continuum of type 1 diabetes, from being at risk of developing the disease to getting newly diagnosed in the disease, where your autoimmune system is progressively destroying the only cells that produce insulin in the body, i.e. the pancreatic beta cells within the islets of Langerhans. And that's the only sustainable solution is insulin therapy for people that have lost all the beta cells. And then there are other things about the day-to-day living. This is a disease that requires 24/7 management. You have to titrate every meal you take, your insulin dosing with that, with your glucose values, and very small mistakes are often not forgivable for the patient here. And they lead sometimes to very extremes of low blood glucose and high blood glucose levels, and in some cases also lead to death in those extreme cases. So we have a very important focus in the area of improving outcomes in people with diabetes, as well as cell replacement therapies. For today, one more click, please. For today, in the interest of time, I will focus, because this was more of an autoimmune disease panel, more on the autoimmunity aspect of type 1 diabetes. But please remember that all of these other aspects are equally important in an individual living with the disease or at risk of developing the disease. Next slide, please. So I'll highlight some of the advances, and while I do that, I'll list some of the gaps, and then I'll end with some opportunities for this panel to think about. Next slide, please. So we have had many successes in evolution, and I did not do it in a chronological order, but I wanted to give some of the hallmark findings. One was staging of the disease. My previous presenters also spoke about it a little bit for RA, and this has been a paradigm shift in how we think about it. In the past, type 1 diabetes, and not in the past, even currently, type 1 diabetes is diagnosed when you have a particular marker in your blood, your hemoglobin A1C, the glycosylated portion, at a certain percentage level. That is the standard by which we go when you're then put on insulin therapy. And that's when you're diagnosed to be type 1 diabetes. JDRF, along with a body of investigators around the world, with 20 years of genetic and environmental evidence, posited that you actually have type 1 diabetes before you're declared to have type 1 diabetes. And this staging has been paradigm shifting. And while there's innate immunity, and that's a very critical factor, as well as genetic predisposition, you pretty much start showing signs of type 1 diabetes through autoimmune markers in your blood way before you become insulin dependent. And the stage 1 is where you see these antibodies in your blood, antibodies to the pancreatic beta cell showing up in your blood. And then progressively, as you lose your insulin producing cells, you show glycemic disturbances, glucose values swinging up and down throughout the day. Your hemoglobin A1C, the gold standard marker approvable by FDA today, starts climbing up and up and up till you reach the 6.87% cutoff. So there is a lot we can do early on and intervene to, again, echoing the previous presenters, to either slow down, halt, or reverse the course of the disease. And one of the key successes we have had is to utilize, and one more click please, utilize this autoantibody, and we're now in the process of working with regulatory agencies, both in the United States as well as outside the United States, to qualify these autoantibodies as being diagnostic for type 1 diabetes, because it's not a matter of if you will develop the disease, it's only a matter of when you will develop the disease. If you have 2 or more autoantibodies, your likelihood of developing the disease in a lifetime is 100%. And your likelihood to develop the disease in 5 years' time is 50 to 70%. So it is a pretty good marker, and it opens the floodgates for therapy development from the academic sector as well as from the private sector here. And so we wanted to really we look at this as a paradigm shift here. And what I've summarized here is about 20 plus years of research here. Next slide, please. So we need to screen for risk. That's a very important thing. Who is at risk? Why is that person at risk? Is there a family history? Is there no family history? What is the environmental trigger? Where we are today is by screening, while we don't have a preventive or curative therapy to offer to the families, which is a big downside to it, but we are able to significantly reduce a very dangerous condition called diabetic ketoacidosis, which I'll speak about in a second. Generally, there's very low awareness of the disease because it's largely asymptomatic. It's almost essentially asymptomatic until you go into these extreme symptoms of diabetic ketoacidosis. Knowing your risk helps you manage the disease when you get the disease, because currently we can't offer you a therapy. And also, because we don't know the 90% of the people at risk, the progress in drug development is very, very slow, because the number of people available for testing in the clinical trials are far fewer than we would like to be. Where we want to be is essentially flip this paradigm. Where we want to be is screening becomes a part of preventive care task force, part of healthcare system adopted in the US and globally, as well as we accelerate the development of disease-modifying therapies. And that's why screening becomes so important, because it's a natural segue to the development of therapies that can change the course of the disease. One slide on screening, one more slide on screening, please. Next slide, please. This is a busy slide. I'll hit the high points here. I already touched upon reducing diabetic ketoacidosis. This is an extreme condition when your body develops extreme, because they're metabolizing, because they have a lack of insulin, you're starting to break down fat and other products for energy production. You develop ketones, your blood gets acidotic, you go into extreme cases and sometimes go into coma, and unfortunately a few people pass away from it. Without screening for the risk, the people that end up in DKA diagnosis, and this is in the people that are covered and we get picked up through insurance. So the number is likely much larger than 60%. Just by introducing screening, even without a disease modifying therapy, we have been able to reduce it to 1%, 3%, below 5%. And then we are learning more that while family members with T1D have an increased risk of 15-fold, 85 to 90% of diagnoses don't have a family member. So we need to move into general population screening to increase, to cast the net wider and pick up the people at risk. There is also a big risk, a big need for support, because this is it causes significant psychosocial stress, and they need to see an endocrinologist as opposed to a regular practitioner, because the knowledge bank there is much different in terms of the attention they need and the care they need here. And then we are working on, akin to, again, the previous presenters, to go beyond autoantibody screening and layer on top of that to increase the sensitivity, accuracy, and more important, the prognostic value of the rate of progression of the disease by layering on top of that metrics such as glucose variability through a new device, well, not new anymore, it's about 10 years in the market, called continuous glucose monitoring system. It's been life-changing for people with diabetes, as well as genetic markers that predispose. And we think we can have a far more advanced prognostic tool, and that's a new opening for research. It's a current gap, but there have been advancements there. Next slide, please. The goal for screening actually is to cure the disease, to prevent the disease. The screening, as important as it is today we do not have, which I've mentioned already before, we do not have any therapy to change the course of the disease, either the immune to rebalance the immune system, or to replenish the lost beta cells that produce insulin that have been damaged by the immune system here. We don't have any therapy right now. And our vision as a future is commercially available therapies that can change the course of the disease. Again, slow down, halt, or reverse the course of the disease, either by immune or beta cell therapies or combinations. That is our North Star here. Next slide, please. There have been advances, although nothing is approved to date yet. There have been advances, and I showed you the staging of the disease, which has been paradigm shifting. And I apologize, stage 4 is not an official stage. It is basically people living with type 1 diabetes and on continuous insulin therapy, either about 6 to 10 shots a day or on a continuous subcutaneous insulin pump with continuous glucose monitoring. Our goal, as I mentioned, is to have therapies that rebalance the immune system and or reproduce the beta cells producing insulin in the body. It's likely that a combinatorial approach will be required, which requires a paradigm shift in thinking of clinical trial designs, which I'll get into in the last slide, as well as how we approach the disease. But this is the pipeline we have currently. It may not be exhaustive, but it's pretty encouraging. But every advance opens, I think the previous speaker mentioned this, opens new doors of research and new pitfalls or landmines that we need to be addressing in the world of research and development here. And I'll try to get into that in the next slide. Next slide, please. This just shows that while we are the type 1 organization in the world, we know that we are only a part of the ecosystem. We require several partners, and I'm delighted to say that we have partnerships with some of my previous speakers of their foundations, such as National Society for Multiple Sclerosis, Arthritis Foundation. We have significant collaborations with several other disease foundations, as well as pharmaceutical companies, just in the immune space. And a lot of collaborations, one more click please, with the National Institute of Health and NIAID. But I'm hoping that this will grow furthermore here. And one of the crown jewels in our partnership is what we call the Type 1 Diabetes TrialNet Coalition here. And they have been instrumental in screening as well as a lot of disease modifying therapies, in addition to several of the other partners listed here that JDRF coordinates with here. Next slide, please. Just one example or a case study of the therapy that's most advanced, and a BLA has been filed with the FDA. It's under FDA review now, And here's a history of this allergen-specific immunotherapy. It's an anti-CD3 pathway that actually 25, 30 years ago was being developed for a form of arthritis. And then one of our investigators who had a career development award and now is the pioneer in the field, at the time found mechanistic link for type 1 diabetes. Now, fast forward 20 years, 25 years of research in genetics, biomarkers, clinical studies, this particular therapy showed it can delay the onset of disease by 3 years or more. It's still in further follow-up here. And our venture philanthropy arm called T1D Fund has invested in the small biotech company Provention Bio and working with all our partners in trying to see whether we can have the first therapy, disease-modifying therapy for type 1 diabetes approved in this particular calendar year here. And so fingers crossed, this would definitely, and I repeat myself, would be a breakthrough for type 1 diabetes and open the doors that in not only in the psyche that yes, type 1 diabetes can indeed be prevented and cured, but also really open a lot of R&D arms that have been stalling through these valleys of deaths as we go across the pipeline and its various stages of inflection points. Next slide, please. Opportunities. I just have one slide, a busy slide summarizing the opportunities that I'd open it up for discussion at the end of the panel if time permits here. Next slide, please. This will be similar to some of the previous speakers here, but I've categorized them into some kind of areas, binned them. There's clear overlap between these 4 boxes here. One is enhanced knowledge sharing. So, the usual suspects of sample banks, data banks, but I also strongly believe in a multidisciplinary portal. It is an autoimmune disease, type 1 diabetes, but most of its manifestations are metabolic. Glucose levels, diabetic complications, end organ failure, like nephropathy, cardiovascular death, highest cause of mortality. So there has to be a multidisciplinary approach here to solve this problem. If quote unquote type 1 researchers could have done it, we would have done it by now. And so that's an important gap, as well as the global lens one needs to take and encourage collaborations with other federal funding agencies to the extent possible as JDR works across the globe to do that. Create partnership platforms, and I don't mean that in a facetious way, I mean in an intentional way. Clinical trial protocol advancements, and a previous speaker mentioned, is it even ethical to have placebo control in all of the studies? We understand the need for it, but how can we have these advances in the design as well as get more innovative in this 21st century here? And cross-disease fertilization across common pathways, shared genetics, multi-omic analysis, mechanistic studies, so on and so forth here. Incentivized translation. There is a lot of very, very good IP coming out of academia as well as small biotech company, but it's very hard. They don't have the incentive to translate here. What are the opportunities we can present or enhance the ones we have right now to make that happen? As well as, which I didn't have time to touch upon today, is regulatory pathways and guidelines. Currently, they are very minimal at best. And how can we create a pathway so that there can be seamless development of these therapies that can improve people's lives with type 1 diabetes or at risk of type 1 diabetes? And what I didn't mention is, unfortunately, a lot of people with type 1 diabetes also have a second or a third or a fourth autoimmune diseases, celiac being the most common overlap. So there is definitely room for cross-collaborative research here. And very importantly, expand the people pipeline. This endocrinology is not a medical practice. I know there's a lot of doctors on this line here that people are chomping at the bit when they come out of med school here. There's a dearth of endocrinologists in this country and globally, given that diabetes itself is a pandemic for the last 100+ years. And so how can we encourage basic scientists, clinician researchers, and as well as the diversity and inclusion aspect of it, because this disease is now seen in every ethnic group. And there's a severity, just as the previous speaker said, in renal failure in the African-American population, much, much more than in the other populations with type 1 diabetes. So a lot of room to grow here. And my last slide, in the next slide, please. I will not go over these. The same points I made earlier, I just wanted to break them into categories about, as a summary, the take homes from this particular 20-minute talk would have been that, some of the basics on type 1 diabetes that you probably were aware of, but I just wanted to reiterate in this slide, they will be available for you if you want to refer back to them. But importantly, this disease can affect anyone, anywhere, at any age during their life. It's no longer a juvenile disease. Several advances have been made in understanding the natural history of pathogenesis, disease staging, screening is available now, and let's build on them. Let's enhance them further. Opportunities mostly are in every area highlighted earlier on, but most importantly in the cross-disease, cross-autoimmune disease platform setting here. There's a lot we can learn from each other. And I just put there to end it, to try and train people to prevent the brain drain, to go into some of the other disease areas, because there is a dearth of people to take care of type 1 diabetes as well as researchers in T1D. So I'll end with that, and thank you for your attention. Hopefully I was able to keep to my time limit.
You did very well. Thank you very much, Sanjoy. As a matter of fact, there is a lot that we can learn from each other. That's a very nice sort of ending comment. Once again, I will hold questions until the question period and move on to the advances and opportunities in inflammatory bowel disease. Dr. Carol Heller, as the Chief Scientific Officer at the Crohn's and Colitis Foundation, Dr. Heller is responsible for all mission-related activities, including the research efforts and patient and provider support and education programs. She previously worked for Weill Cornell Medical College, so we have a lot of representation from Weill today, where she was Associate Dean of Intercampus and Industry Initiatives. Thanks very much for being with us this afternoon, Dr. Heller.
Thank you so much for inviting me as a representative of the Crohn's and Colitis Foundation to talk about the opportunities in inflammatory bowel disease and how we look to NIH and ways possibly to accelerate how NIH funds research to get to outcomes more quickly. Next, thank you. So I'm going to go over very briefly the epidemiology of Crohn's disease and ulcerative colitis, IBD, recent research advances, the urgent need for better approaches, and really focus in on the greatest opportunities for accelerating impact and how we would like to see NIH put more focus, and that is on bedside to bench approaches. And I'm going to focus in on environmental triggers, and it's been interesting to hear pretty much all of the other disease representatives talking about the importance of environmental factors in their diseases. The concept of endotypes and how it's been applied in other diseases to great effect. And standardization, we're really talking about, if we're going to talk about the need to really focus in on bedside to bench, we really need to define bedside carefully and in a standardized way. Next slide. So epidemiology of IBD, I really am respectful of the Multiple Sclerosis Society that they were able to have this terrific study and look at their prevalence. In IBD, we have a range of prevalence from 1.6 million based on medical records to 3.1 million, which was based on a survey that the CDC asked of people to ask them whether they had Crohn's disease or ulcerative colitis. CDC has now funded the Crohn's and Colitis Foundation to do a prevalence study, and we're really using claims data as was pretty much described in the MS program, and probably we have very preliminary findings, not ready for prime time, but it's indicating that we're probably somewhere in between the 1.6 and 3.1 million. The peak occurs between 10 and 40 years. There are diseases of more of younger people. So Crohn's a little younger than ulcerative colitis, but they're lifelong diseases. So the mean age is still in the 40s. There is a rising incidence in newly industrialized countries and in immigrants from those countries to more industrialized countries, which really gets at sort of the concept of environmental triggers being really important. Next slide. Like the other diseases you've been hearing about, IBD is a complex disease. And we think about it as having sort of 4 pillars. immune response, genetics, microbiome, and the environment. Next slide. So when we think about recent research advances, and I'm limiting them to very, very few to really spend the most of my time on thinking about how we can advance more quickly in this area. Next click. So for immune response, we've been in existence for more than 50 years, and from the beginning, funding efforts really to look at the immune response. And there's been great advances in understanding the immune response in Crohn's disease and ulcerative colitis, with an increasing understanding of the role of each immune cell type. And sort of the advancement of single cell analyses has contributed and will contribute even more to this understanding. In genetics, as we heard yesterday with MS, the identification of various genes that make people more susceptible. There are hundreds in IBD of these SNPs. But what's happening now is that people are beginning to cluster or sort of put the genes into pathways so that we understand how these genes fit into the picture of Crohn's disease or ulcerative colitis. And that enables the researchers to begin to identify potential drug targets that are relevant for those genes. Next slide. I'm sorry, next click. With the microbiome, it's been fascinating and gratifying to see that everyone really for these immune-related diseases, autoimmune diseases, are really recognizing the role of the microbiome. Of course, in IBD, this was recognized quite early because of the gut microbiome. And, oh dear. And so what we have been spending time and effort on this for more than a decade. And our research that we funded, as well as NIH, has contributed to this dramatically, really beginning to identify what are the desired bacterial patterns within the gut microbiome and the metabolites from those bacteria. And so this is now informing therapeutic strategies to address the microbiome directly. Next slide. So in the environment, this is really an emerging area. There has not been a lot of funding for research in this area. At the Crohn's and Colitis Foundation, we see this as an important area, and we have been funding some early work related to the importance of psychological stress and diet, and I will talk more about diet a little later. Next slide. So there's an urgent need for better approaches in inflammatory bowel disease. There's no cure. As I said, the onset is often young. So these people, if you get it at age 13, you have it for life. It is, and so not only is it a chronic progressive disease without a cure, but it's associated with an increased risk of colorectal cancer, and some of the medication, the treatments are associated with increased risk for other types of neoplasms. So, this is a case for treatment where it's really whether you view the glass as half full or half empty. Fewer than 50% of patients have a long-term response and remission to therapy. But that means that more than 50% do not. And so there really is a challenge and a need for new therapies to get at the other 50%. And unfortunately, there are currently no biomarkers that are predictive of response to therapy. So patients are started on drugs or prescribed drugs, whether they are likely to respond or not, and then it's basically a trial to see whether it works or not. And then all of this is associated with high surgery rates, and about 70% of Crohn's patients end up requiring surgery, so many with multiple surgeries, and about 30% of patients with ulcerative colitis. Now those numbers are coming down a little with the use of biologics and other disease-modifying agents, but they're still very high. Next slide. This is where we see the greatest opportunities for accelerating impact. So, and I say accelerating because certainly NIH funds in a way, and all of the work on the immune response have probably largely been attributed to NIH funding, but it's been a very slow process to go from this funding to a new therapy or to breakthroughs that can get you to new therapy. So we are really thinking, how do we accelerate to get to this impact? And as I said, we really think we need to focus on a bedside to bench approach. And this comes out of our work. Every 3 to 5 years, we hold what we call a process to develop the challenges in IBD, which are published. And this, we did this in 2018 and 19, and we had 100 experts, patients, caregivers, industry, researchers, surgeons coming together in 5 different groups to really identify where are the key gaps that need to be addressed to accelerate. What do we need to be thinking about and working on in the next 5 years that will change the trajectory to get to cures? We still are hoping for cures, or at least improved therapy with improved quality of life. One of these areas was environmental triggers, and I will go into a little more detail on the next slide. Other that I'm sort of pulling together from 2 groups. One group focused on precision medicine, and the other group focused on the need to, and we heard this from another speaker as well, the need to have the preclinical models reflect the human disease. So making sure that you are tying up, connecting the preclinical models to mechanisms, and even using samples from humans to make sure that you don't have animal models that are not relevant for the human disease. And we're thinking about this as IBD endotypes. So an endotype is a term that's being used now referring to underlying mechanistic pathways that then relate to a cluster of phenotypes. And I think it's relevant, we say, for IBD, but I've heard in the previous comments the fact that some of these in the juvenile arthritis are not, the categorizations are not matching up with the biological categorizations. And then if we are going to focus or put an emphasis on bedside to bench approaches, as I said, we really need to have standardization in the definition of bedside so that we can compare apples to apples. And for this, we need common data elements in IBD. And we heard about those in MS yesterday from the NIH speaker, talking more about it in terms of outcome measures. I'm going to be mentioning in terms of phenotypes and categorizing patients. Next slide. When we think about environmental triggers, the research gaps is, and this is true for IBD, and clearly I heard it with the other conditions as well. How do the environmental factors influence the causative role? Do they play a causative role in IBD, susceptibility, progression, and relapse? And to do that, you really have to have well-defined patient cohorts and begin to recognize key environmental factors. For IBD, we think about, as I said, psychological stress, food, a major environmental factor here, smoking, which has an aggravating effect on Crohn's disease, but somehow an ameliorating effect on ulcerative colitis, which has never been teased apart to understand why, and possibly infections and antibiotics. We need to be able to then understand and recognize the biological signatures associated with these exposures, and then that relationship of the exposure to clinical outcomes, and then the mechanisms connecting these environmental exposures to clinical outcomes. So we really need a better handle of the epidemiology and exposome. As I said, a focus on priority cohorts where we're really addressing critical unmet needs, and systems biology approach and hypothesis-driven studies. And this this needs assessment is in inflammatory bowel disease from 2019, so readily available for reference. Next slide. What the Crohn's and Colitis Foundation decided to do in the area of environment, besides looking and funding efforts in the importance of psychological stress on the disease, is really begin to understand food. all of our patients, the first question the patient asks, or one of the first questions they ask is, what should I eat? And at this point in time in the 21st century, we still cannot answer that question. So the Crohn's and Colitis Foundation decided that we needed to launch a precision nutrition initiative. We are now funding 4 different studies. They relate to trying to evaluating in randomized clinical trials, rationally designed anti-inflammatory diets, identification of pro-inflammatory trigger foods, so getting a patient into a clinical remission and then reintroducing foods to see the impact, identification of biomarkers and so they will be exploring using various omics analysis to try to identify biomarkers to predict and measure the response to these diets so that we can see which people will respond to which diet. The other thing that our goal and one of our fund programs is a pretty high risk program in looking to see, are there in silico predictive tools based on data on food and metabolites of food and responses to these metabolites in the public domain that can be used to develop predictive tools that can then lead to more evidence-based and better evidence-based therapeutic diets to evaluate in trials. But we've been around for more than 50 years, and we're spending a fair amount of money on this, but this is a huge question and it's relevant for inflammatory bowel disease, but it's probably relevant for these other diseases as well. And we recognize that NIH has launched, it just came out with a nutritional strategic plan. Nutrition is an effort from the Common Fund of the Office of the Director, but they're focusing very much on the building blocks, and we think there is really a need to get into sort of the diseases and the impact on patients. Next slide. So the next approach that we think is really important is to really begin to tease out this concept of phenotype, which is the clinical presentation of the underlying mechanistic pathway, and really understanding the underlying mechanistic pathway. So patients with a specific endotype will present with phenotypic clusters of diseases. And it could be that some of these endotypes really are going to cross some of these autoimmune diseases. We don't know that yet, but we really need to have a greater understanding of this. And we know that this approach to research and to categorizing patients has been applied to asthma. And now, from quoting from this publication, the term asthma is now considered an umbrella diagnosis for several diseases with distinct mechanistic pathways and variable clinical presentations. And this is influencing how in asthma they are treating patients with asthma. It's not like you have asthma, but you now have these distinct phenotypes and endotypes of asthma which guide the therapy. And with the heterogeneity of inflammatory bowel disease, we think that this is really important. Next slide. So endotypes are really needed to unravel the heterogeneity. And as I said in my list here, it's not, we haven't vetted this with all the experts. This is just a list of representative ideas on what could be relevant. But we understand that certainly with the heterogeneity that it influences, we see it in disease presentation, disease course, response to treatment, and response to environmental stimuli. As I mentioned, we've been funding efforts to understand response to psychological stress. And what we found is some patients are very susceptible to relapse because of psychological stress, and others aren't. So there's a lot of heterogeneity in this disease. And so we really need to understand the underlying mechanisms and tie them back to the patients. And then that will lead us to new biomarkers and targets that are relevant and hopefully more effective within specific subgroups. Next slide. So this gets to standardization. As I said, if we want to have increased focus on bedside to bench, we clearly have to standardize the definition of the bedside so that we're not all talking, when we talk about upper GI disease, we're not talking about having different definitions. So for example, clinical data collection, how patients are classified varies greatly. And so then it makes it difficult to compare studies to validate them. An example was looking at studies in a recent publication that there were 2 academic studies. They evaluated factors associated with response to the same therapy in patients with isolated upper GI disease. They used different definitions of isolated upper GI disease. They were both underpowered to generate definitive results, and you couldn't do anything with that. Next slide. So we believe that there's a need for common data elements in IBD. And we would like to see NIH develop this as they have done this with other NIH institutes. And this is to create a set of common data elements and associated tools and incentives, because creating the elements and tools doesn't get it put into research and practice and clinical studies. There need to be incentives because this is a challenge. Everybody likes to use their own definition. So for the process, we would recommend that NIH, NIDDK really follow the process that other NIH institutes have implemented in developing CDEs. Asthma is a good example. We just heard from NINDS that they're doing that with multiple sclerosis. And for IBD, we think the need is in phenotypic definitions and an incentive to use it, because this would be relevant for clinical trials, translation work, and even basic research if they are using clinical samples. Because the clinical samples, you have to define who that patient was and the metadata around that patient to be able to draw conclusions in the basic research. So the outcome is to guidance to yield more efficient research that data can be shared, validated, and compared. Next slide. So in conclusion, I want to go back to sort of Pasteur's quadrant. We think that innovation is needed to accelerate positive outcomes in IBD. NIH is commendable for all of its efforts and the research it's done and the advances that have come as a result of this research. But it's a slow process and often an inefficient process where research doesn't actually lead anywhere. So we think that there's a need to increase the emphasis on bedside to bench, not do away with the basic research quadrant here, but really think about bedside to bench research, the Pasteur quadrant, where there's consideration of use that guides the quest for the fundamental understanding. And we think the 3 immediate areas where this is really important and light has to be shed through research efforts are environmental triggers, the study of endotypes, and standardization of the clinical phenotype. But I also want to emphasize that in your recommendations to Congress, I think that it's important to note that there's a need for increased funding to be able to do this. NIH is sort of established in the way that it gives out resources. And it's a large organization. It's very hard to change a large organization. They have been funding investigators in a certain way for a very long time, and it's hard to make changes. Hard for them to change their point of view and how they fund things. So that if there's a mandate to change, I would really hope that it is accompanied by an increase in budget so that they can then take the extra funding as the mandate and to fund to this approach. So thank you very much. Happy to answer questions.
Thank you very much, Dr. Heller. So I'm going to open this up to the floor with the committee members and other public comments. and have a general discussion related to the questions that will be asked. Looking at what we've had on the screen at the moment, there have been some questions from William and from Michael. And suppose I start with that. Awo, if you have some, there are a couple of questions on the Q&A from the public, and if we can add to that, that would be helpful. So let's start with William. Did you have questions initially to Dr. LaRocca? You're on mute. I think you're on mute.
Is it for me?
Yes.
Oh, okay, I'm sorry. You called me William. I was looking for Bill.
Well, I usually do, but
It's okay.
I used your full name.
You threw me a curve. That's okay. Yeah, Michael addressed some questions, and I do too. I guess one of the things that when I look at these are great presentations, I look at each of you talked a little bit about priorities and for the disease in your organizations. And I guess the question from your point of view, when you look at what NIH is doing now, multiple institutes with multiple responsibilities and expertise across the board, current funding levels, is there anything AID or any of the other institutes, NINDS or others, can do to address what you consider some of the gaps are? Are they covering them sufficiently? Are there areas that are left off? And how any recommendation for helping coordinate activities across institute?
Maybe, can I start? I'll make two specific comments. From the investigator point of view, I found I respond to RFAs, requests for applications, much more so than program announcements, because there's dedicated money for RFAs. So one suggestion would be, I tried to highlight quickly, a few areas of recent observation that I think have, great potential to be extended. And others who spoke also identified some important areas, and there will, of course, be others. I think that the investigator community would be very responsive to RFAs that the different institutes could identify that have dedicated money. You look at the RFA and you think, yeah, I have some ideas there, and you push yourself a little bit. And I think that approach, maybe it means shifting money around a little bit within each institute, might be valuable. And then the second idea would be, and it came up a little bit yesterday, would be for two institutes to come together and to co-fund an initiative. It might be in the form of an RFA. Ideas that seem particularly important would be, how do environmental triggers work at the biologic level? How can we advance understanding of distinctions between African Americans and European Americans in terms of genetics and molecular pathways? So those are two approaches that might mean shifting around funds, but I think would be responded to by the investigators.
Could I add to that?
Sure.
Couple of thoughts. I think that one of the things that's maybe been somewhat missing, which has been filled in by PCORI, is involving the people who live with disorders much more in the not only the conceptualization of research, but establishment of priorities, and also the design of research. Because anyone who has ever sat in on a data and safety monitoring board as you track recruitment knows that one big challenge to doing good research is just getting people interested. So I think that more of a multi-stakeholder approach would, I think, make a big difference. And I think the other thought, which sort of goes along with that, is to maybe get away from too much of a reliance on investigator-initiated research. Not only through, some of the mechanisms Mary was talking about, but also the participant-driven research model. But also just trying to look at the whole landscape of a given disorder, and what really needs to be addressed, rather than just sort of leaving it to chance, to finding investigators. Because I think what we found is that if you, and you don't even necessarily need to have earmarked funds for a given topic, but if you just express interest in the topic, I mean, that's enough to at least push things in a certain direction. So I think there's a lot of mechanisms that could be utilized in order to better cover the knowledge areas that we need to enhance.
Bernie, just I know this, I'm agreeing with parts of what Mary and Nicholas mentioned. Just one more thing is that I don't know if the NIH currently has, but do you have an industry advisory panel? And what I'm trying to get at is not for necessarily to collaborate with them, although there's nothing wrong with that, but also to find out what are their gating factors or rate limiting factors. Why is drug development in certain areas, and certainly in type 1 diabetes, the disease I'm representing here, having no disease modifying therapy, what is the inertia, what are the barriers, and what can NIH do to help overcome those barriers? It could have to do with patient stratification, it could have to do with long recruitment, no absence of registries, access to EMR records. And I'm not saying NIH can solve all the problems, but at least to hear them out, to get a completely different perspective, in addition to the foundations and the investigators on this call here. So that's a suggestion if it's not already ongoing.
Very helpful.
And I'd like to add about the sort of another dimension, and that is that, for example, if you want to study environmental triggers, it does really require a cohort of patients who are well characterized, because you have to bring them in, you're going to have to follow them longitudinally. So NIH is supporting the All of Us program, but there needs to be more resources to support long-standing patient cohorts to answer some of these questions, because otherwise they're just not going to be able to be answered. Now, we have one at the Crohn's and Colitis Foundation, but it would certainly help if NIH were able to support that or expand on that, because that's where we're going to see really breakthroughs in understanding underlying mechanisms, heterogeneity, whether it's African American, whether it's women. That's where we're going to see it, by doing omics analyses and multi-omics analyses of well-characterized and well-followed patients.
I think we need to see. I think we need to see more co-funding between the federal government and the advocacy organizations. We did a program in which we funded studies of gender and autoimmunity with the NIH, which was very successful. I think we need to do more of those kinds of partnerships because I think they're very productive in a way which is not really possible when the NIH funds alone or the advocacy organizations fund alone. I think it's what results is more than just the sum of its parts, I guess what I'm saying.
Yeah, I just want to add also to this idea of, the power of the cohorts and addressing this challenge of heterogeneity, which has shown up in all of our presentations. And it's a challenge, for all of research and really the fatal flaw of many applications, yet we can't keep running away from it because it's the reality, and it's, the answers lie in that heterogeneity. So if we could find a way to creatively reframe how we look at the heterogeneity, and I think you know, it's both the biologic factors that are driving it and a lot of the social factors. And we tend to still have people studying one or the other and not the two together, because that's expensive and complicated. But if we could find a way to support studies that really integrated understanding both of the biologic and the social determinants together, I think we could maybe move the needle on this heterogeneity and not be running away from it, and rather really letting it guide us in terms of understanding what is going on here. That I think that would be helpful across all of these conditions.
I have a number of committee members who want to ask further questions. I'll just go over the list. It's Michael, Glinda, and Emily, and then Awo, if you would ask the questions from the public, that would be helpful. So let's do those in the order that I mentioned. Michael, Glinda, Emily, and then Awo.
Well, most of the questions that I was raising, I've gotten responses from. One of the things that struck me was the different model that NCI used in setting up its cancer centers, which were not specific diagnosis based, but were quite general, but brought together national collaborations that are both very long lasting and able over time to get uniform procedures and uniform studies. Do you think that kind of model would work in autoimmune diseases?
I'd like to say yes, but really based on, as I was listening to the presentations yesterday and to your point today, sort of the concept of best practices, that NIH really needs to identify its best practices, and through NCI, this collaborative effort that doesn't focus on disease, specific diseases, but best practices that can then be implemented and be monitored. So for example, in some of the divisions within a particular institute, they're very patient-centric, and they bring patients in for prioritization. Yet in other divisions within the same institute, they have no effort in patient centricity. So it seems like all of our diseases should be able to benefit from the best practices within NIH and ensure that they are implemented widely and consistently, and it would have to be monitored. So if there are learnings from NCI, let them be applied to the other institutes.
Thank you. Glinda?
These have been really terrific talks, and I really like the way they've built on each other and the way, you know, you can see the connections across the presentations. So I want to go back to this idea of the environment and how that aspect can be supported more strongly by NIH. In particular, Dr. Heller mentioned the role of newly industrializing nations and the experience of immigrants from these nations. And so two things struck me when I heard that. One, you know, when I think about the industrializing nations, I think of widespread environmental contamination that's present in these situations. Heavy metals, I mean, all sorts of things that we would never, that we can't even imagine, you know, but that's what people live with. And when you think about the immigrant experience, that's probably one of the most stressful experiences anyone will have in their lives under the best of circumstances. And so many immigrants are not arriving here under the best of circumstances. And so that interaction between stress and environmental contaminants, and how that may play out through a lifespan, like even in utero exposures and early childhood exposures, and that interaction with stress, I think is a really interesting area in terms of immune response. I don't know that, I don't really think it's been appreciated or been explored well within the autoimmunity arena. It has to a certain extent, but not probably not as widely as it could be. And so I wanted to get your sense of whether you see a value in that area of research, and if so, how NIH can support it or encourage it or enlighten people to it, or to the questions that could be asked, and how your individual advocacy organizations think about that broader aspect of environment, not just diet and smoking.
So the broader aspect, you mean that there are many factors that influence it?
Well, when we're thinking about environment, maybe we need to follow different clues, not just the diet. I mean, obviously with IBD.
No, absolutely, absolutely. And we would love to follow the, the episome or the exposome, but that requires a lot of resources, to your point. So that's beyond the scope of what the Crohn's and Colitis Foundation can fund. This is something that NIH, and this is where I would see sort of an inter-IC effort, because this is a big effort to really figure out how you are studying the environment when you're looking at the exposome, right? And this is a big effort requiring a lot of resources and a lot of different methodologies that probably the other ICs are not that familiar with and are not currently funding. So here's where I see a great opportunity for inter-IC efforts. And maybe it comes out of the Common Fund and the director's office at that point.
Emily, did you have a question?
Hi. So first of all, fabulous presentations. They were all really informative. I enjoyed listening to them. So I'm kind of following on to what Glinda was just mentioning, but from the lens again of, it seems like one of the themes that came up today was about cohorts and epidemiologic studies and environmental research. And as an epidemiologist myself, this is of great interest to me. And one of the challenges I've seen over the years is that pure epidemiologic and descriptive research and work is really challenging to get funded through the NIH for a few reasons. One is that there seems to be a persistent bias towards hypothesis-driven mechanistic research and not as much enthusiasm for funding some of the infrastructure development and those sorts of things that can lead to these well-characterized populations. And another aspect is just the time element that's involved in these things. To create something and follow a population, of course, can take years, and that is in some tension with the typical 5-year funding cycles of the NIH. So Dr. Crow, for instance, mentioned RFAs as being a potential mechanism as opposed to investigator-initiated research to move towards some topics more keenly of interest to the autoimmune diseases, for instance. Are there other strategies you can think of to help pursue these sorts of long-term investments and that might be in tension with the funding cycles that currently exist?
I wonder if there could be mechanisms that highlight or even require collaboration, say, between epidemiologists and others coming at the questions more from the biology point of view. I mean, I guess we would call that multidisciplinary research. And, I think a theme that we're all coming back to is that messaging from the NIH and the institutes can be very impactful, I think, on the way the investigator community responds. So, that could be one approach to look for research that brings together, different disciplines that would, move both areas forward or synergize, I guess.
But I think that you make two excellent points about the NIH more reluctance to fund infrastructure and really long-term studies. And that, to me, requires a different philosophy from NIH, right? A different mandate, because that is they have to believe in that, and then they would figure out funding mechanisms to make that happen.
I think the elephant in the room is our fragmented healthcare system. We've worked very closely. A lot of the people on our epidemiology project were from Canada. And I think that if we had a single payer system or something, something resembling a single payer system, or even just a single data system, it would really facilitate a lot of what we're talking about. This is what they've been doing in Canada for years. And I think we can learn a lot of lessons from them once we get past the politics that are involved. But I mean, that's where we're really wasting so much time because we don't have this data in a way that we can really utilize it in an economically feasible way over a meaningful period of time.
Thank you. Awo, could you bring us up to the questions you still have on the Q&A?
Yes, before I do that, I actually wanted to turn it over to Sonia. I see a question from her for Dr. Heller.
Oh, I mean, Dr. Heller and all the other presenters, and thank you. I was just wondering, there was not much mention about gender. What are your priorities for gender-based research from your foundations? Yeah.
So gender has not come up as a priority for inflammatory bowel disease, and other than sort of the heterogeneity of the disease. Maybe, you can be, I don't know, you want to be a little more specific about that.
Sure. I mean, issues regarding, pregnancy, fertility, etc., that are really important to patients, I think.
Definitely, and right. And we have funded efforts in that, the piano study to monitor patients that way.
Marie Mancini yesterday noted the studies in lupus pregnancy, which I think have been very productive. And, as I noted, the more basic and mechanism related research to understand the female skewing, I think is really just starting to take off. So I think that will be a very productive area. And
gender has been a priority for the MS Society for a long time. The MS population is, 3-to-1 or 2-to-1 female to male. And also there are interesting things that happen to the course of MS related to pregnancy and childbirth and so forth. So there have always been a lot of hints to things that are important about gender and multiple sclerosis. And it's just unfortunate that we haven't had the opportunity to do more of that research, and also that the NIH has not really, from what I could see, has not really supported as much as would be desired.
Thank you.
Awo?
Yes, so there are, I see that we are just over, there are only 2 questions in the queue from the public, and just based on the time, I'm wondering if we should follow up with them separately. These are they identify more of gaps in the research, and so we can follow up on those outside of the meeting.
If you could do that, that would be fine. Are there any other questions from the committee that I missed? Well, seeing none, I really want to thank the speakers today. A lot of insights came that would help the committee in its deliberations. And I also always want to thank those who tuned in today. The presentations from the last 2 days have been extremely informative. And the speakers, as I just said, have really further informed our work. Now, there may be some more questions for the speakers today, since they really honed in on a lot of issues related to NIH, and I'm sure we can correspond further by email or even with some telephone follow-up if necessary. If anybody has any comments or questions, please send those to Henrietta Awo Osayanto, who is the project study director at autoimmunestudy.nas.edu. So those questions should go to autoimmunestudy@nas.edu. And then also, for those who do, please keep in mind that any material you wish to share with the committee will be made public through the project public access file. That is because the National Academies comply with Section 15 of the Federal Advisory Committee Act rules. So once again, I really want to thank everybody for the contributions of today. It's been very helpful. I summarized some on my notes. I'm sure that the NIS team will do the same. And the committee will have a closed meeting on Friday where we can discuss some of these findings and go further in our project report. So thank you, everybody. Enjoy the rest of the day, and we'll see each other again soon. Thank you.
Thank you.